My inside information is currently that might be on hold, and I think it might be on hold because of the cost. I don't care what it's on hold of. It's the best jolly news I've heard for a long time. And I hope it stays that way. I can't see why a profession as robust and healthy as dentistry, who pays such attention to infection control, should be singled out by a government organisation for looking at their infection control standards. You know, they're trying to say that we spread nosocomial infections. That's rubbish. What they say is that a dry socket is a nosocomial infection. No, it's not. It's an endogenous infection. Squadron Leader Thomas, an endogenous infection, one the patient got themselves from probably smoking 2 minutes after they went out and had the extraction. Yeah, there's a whole, again, range of people who don't understand the technical and nitty-gritty parts of dentistry. This is what I was harping on about earlier. You've got to remember you can delegate duties, and I think delegation of duties is the way to go. You must streamline it. Having people like a sterilisation technician is a brilliant idea if you can afford it, particularly if you've got a big practice. You want someone to manage your sterilisation area. But at the end of the day, the responsibility rests with the operator, be it a hygienist, a therapist, a dentist, orthodontist, a prosthetist, doesn't matter. A student, you are the ones where it rests. Okay, this is available for downloading. Don't download it just yet. The new guidelines have gone up to executive. They should hit the web maybe this year, maybe January, but there will be the revised version. And in blue is what is different. We no longer have additional precautions. We have transmission-based precautions. It's what I said earlier. Know the pathogen. What are you trying to stop from happening? So you pick up your transmission-based precautions. Hand hygiene. It is now hand hygiene, hand decontamination, hand decontamination, hand decontamination. The old rules still apply. If you want to go to the loo, then for goodness sake, please wash your hands, all right, with soap and water, please. That would be very nice. But in the clinic, when you're taking gloves off, on, off, on, off, on, and goodness knows I can do that with 10 patients in the morning and call to other places as well. I would hate to think how many gloves I get through in a session. The hand decontamination allows me to do it in a matter of seconds, and my hands are dry. I can change gloves, I can cut back on time. It is the best time saver that we've got, and it is more effective and clinically proven and evidence-based than hand washing in terms of reducing the bioburden on hands, all right? There are a range of alcohol hand rubs available. When you go into private practice, try them all until you find the one you like. I wasn't overly keen on the one that I used this morning. It was a little bit sticky. Our hospital's moved to Johnson & Johnson Aqueum. I don't like that particularly either. I know what I like, and because I'm got a loud mouth and say what I think, they actually get a particular brand in for me. Flinders Medical Centre uses the same brand I like. And the reason I like it is it doesn't leave the residue on your hands. So you need to play with it until you find one that you like. As much as I like, I think it's Dermis Soft or something like that, as much as I like that, other people like the Johnson & Johnson product. They prefer that. So it is an individual preference. When should you wash your hands? Actually wash your hands when you're doing decontamination procedures? When you need to. Not after 5 applications of hand rub, not after 10 applications of hand rub, not after 50 applications of hand rub. Do your hands feel crappy? Yes? Then wash them. All right? Do your hands feel just fine? And if I use the product I like, I can go a whole session and they don't feel at all sticky. all right? So it depends on that. There's no law that says you can't wash your hands, but we're trying to shift people's thinking so that you will automatically decontaminate your hands. And because I treat a lot of sick people, a lot of people with cancer, and they usually come in with a carer or a relative, and the relative sits down, and I walk into the cubicle and I watch the carer or person's eyes follow me around. And you can almost see their body ease when I rub my hands with alcohol rub. You know, oh, infection control. This is going to be all right. And I get back to what I said before. People watch what you do. And is aseptic no-touch technique. Now, this is where the critical instrument, part of the instrument, stays critical, but the rest of you doesn't have to be critical. So the best way I can explain this is someone doing a root canal procedure, and you have examination gloves on, you have rubber dam on because you don't want the file to go down the larynx, you have access to your tooth, and there's a vital pulp you've got to get out. Now, everyone says that's a critical procedure, all right? But you have examination gloves on, you don't have a sterile gown on, you are not doing a critical sterile operating procedure, but the critical point is sterile. So when that file, the tip of it, goes in to the pulp, it is sterile when it goes in. You are not introducing any pathogens. And when you put it back, you keep that tip in a sterile part of your tray. But it doesn't matter if the little handle of the point has been contaminated with your examination gloves, as long as the point that has gone in to the tooth has stayed critical. That's the best I can do to describe aseptic non-touch technique. It applies to taking teeth out as well. The forceps are sterile, but you don't have to have sterile gloves on the handle of the forceps or the elevator. You can if you wish, but that's the logical science of why some people will say, well, why aren't you doing a full-on gown procedure and sterile gloves to take out teeth? Don't need to, but the instrument needs to be sterile as you force it down into the tissues. MROs, there are a range of multi-resistant organisms that's been updated in the guidelines, things like VRE. VRE is a little bit of a problem. It's probably going to become endemic throughout the country. The trouble with VRE is that when people, vancomycin-resistant enterococci, when people get VRE, they shed. They shed it through their skin, and so they can shed it over your dental chair. Now, VRE is really only a problem if you're about to go into hospital and have surgery done yourself, or if you've got a hospital patient coming into your room and you've got someone with VRE that's just been in hospital. So say I've got a cancer patient who's got VRE, comes to my dental chair, and then I've got another cancer patient who's just had surgery, comes in afterwards. If I don't have adequate disinfection and cleaning between those two patients, there's going to be a risk of transfer of that particular organism. Now, for the majority of people, you're not going to be treating patients at risk. So when it gets to MROs, each of you needs to evaluate your practice. For example, in the student clinic I saw this morning, I can't see any reason you had no patients with leukemia, no patients with cancer, and it's going to be up to Andrew Lee to come up with transmission-based precautions for managing that group of patients, okay? It's know your organism. Everything is standard precautions, but if you get an organism that you don't understand, then find out what you want to do. Do you know what you have to do for MRSA and VRE? You have to do a double wipe. And the thing, we use double wipes in our clinic for each and every patient because every second patient of ours has either got MRSA or they're sick or they're really, really crook. A double wipe, they now produce them, they're called Toughies or Clinderls, and they're impregnated with both a ViraClean and a detergent, and you wipe over everything and it leaves this really sort of soapy residue all over everything. And that's how it's supposed to be done. It's supposed to be left wet and to evaporate itself. It works well for us. If you get it right, it works well. Not something I would recommend for routine office practice, all right? But if you're going to have a lot of sick people, then speak to Andrew. Infected healthcare workers and exposure-prone procedures. This has changed. The national guidelines on infected healthcare workers have changed. They basically tolerate 0 viral load, so no virus present in the bloodstream. You are not to have an active viral infection and practice exposure-prone procedures. While I'm at it, we're in a 6-storey hospital, and I was working in clinic next to 1.4, and above me I have clinic 2.5. And they got a block in their suction unit. So all that stuff coming through the ceiling there is actually stuff that was sucked out of the patient and built up, all right? And it's dripped down, and it sort of looks like urine, but it wasn't urine, it was just contaminated blood and saliva and pap and stuff. And that's my cubicle, one of the cubicles anyway, it has dripped into.